So I'm back here at the Masters of Medicine Conference 2020. It's the second conference, and I'm here with the CEO, founder, and the person, the driving force behind HIC, the region's most outstanding hospital when it comes to cardiology, Professor Ernest Madu. Hello.
Hello. Hey, Mark.
Hi. Yeah, and please allow me to say also to welcome. This is his first time to Jamaica. He's the dean, the director rather, of medicine at Johns Hopkins University, Dr. Mark Anderson. Welcome to Jamaica.
Thank you. It's great to be here.
Thank you for taking up the invitation to be here. And it's your first time. So, what are your impressions so far?
Well, I arrived last night around 11:30. I had a great sleep. I woke refreshed, and I took the shuttle for about 4 blocks to our current location. So I still have a limited sampling, but so far I would say everyone is smart and friendly. The conference has taken off in a really stunning direction with truly thoughtful and erudite lectures on the history of Jamaica and how that history plays into some of the built environment that determines where we are in cardiovascular disease today. So I think we've started off on the right foot. It's great.
Let me turn to Professor Madu. When you thought about the conference itself, because this is year number 2, what was your vision?
What we thought, my approach is recognize the problem and then try to find out what solution can be. And sometimes the solutions are not orthodox in a way. One of the issues we recognize in Jamaica is information asymmetry in terms of healthcare delivery. There is a lot of misunderstanding about what drives good quality healthcare, and we recognize that what drives good quality healthcare is not just on the provider side, it's also on the consumer side, right? And that consumer side has to match the provider side. So expectations have to match, and to make expectations match, there has to be information symmetry. There has to be good communication to say this is what the issue is, and these are the possible solutions. And so we decided that it's very important to have these conferences to, one, highlight what the problems are, two, highlight what the solutions are. And in highlighting the problems, we have to highlight the problems in terms of the clinical issues. What are the promoters of cardiovascular disease in the region? And then second, the non-clinical side, what are the structural impediments that make it difficult to provide these solutions? And here are the ways we can solve it. And I think once the consumers of healthcare services recognize that they can also be part of the solution, then it is easier to get to the solution of the problem. And that is what we hope to achieve.
Dr. Anderson, you will be presenting tomorrow. Can you give us some of the highlights of what you'll be addressing?
Sure. I have the privilege of having 2 presentations. The first one will really look at some molecular pathways that our laboratory has investigated for almost the last 25, 26 years, and give you some updates where I think they have real relevance to cardiovascular disease and to our core exercise biology. And then the other lecture is really going to look at some modern history of medicine and try and reckon what is the value proposition in medicine, what we might do to achieve better results, and then a little teaser, a little glimpse into what the future might hold.
What are some of the breakthroughs you're seeing in terms of cardiology from where you sit as Director of Medicine at Johns Hopkins?
And I think we're living in a pretty exciting time, although for cardiology and cardiovascular related illness remains probably one of the largest chronic disease killers of adult population. We see a layer of things that have helped. At the translational level, we're seeing more and more devices that allow people to have repair, say repair of their aortic valve without having to undergo a surgery. This is a big deal because well, it's invasive in that it's done with catheters, but it's not invasive compared to conventional surgery because we don't open up the chest, and that makes a much longer recovery, as you might imagine, and it allows people to go home and to get about their lives very quickly with less of an interruption. I think there are other drugs that have recently come to market to treat heart failure. Some of them purposed at diabetes, which is going to be one of the biggest contributors to cardiovascular disease in Jamaica and the United States and around the world. And these drugs are looking like that they really are going to provide benefits. I think then at the more research level, there are some really exciting things that have happened around various technologies. One of the most exciting ones, in my opinion, is called CRISPR, but it was a system that was discovered in the last 10 years to be where bacteria use it to fight viruses, and this technology can be repurposed to change the genetics of diseases. So an example of that is sickle cell disease, where for most people, there's one tiny piece of a gene that's wrong and could be repaired, but there are other diseases, I think, that may also benefit from that. So I think this is a really exciting time.
Very exciting time. I'm going to ask Professor Madu a question, and I'm going to ask you to listen in as well, because I'm going to come back to you with your thoughts on it. Over the years that I've been talking with you, Ernest, you have been sharing with me your concern for standards. And I want to ask you about standards, not just at HIC with the overall operational standards, but as it relates to, secondly, the delivery of the healthcare standards.
Yeah, Michael, excellent question. I think standards underpin what we do in medicine, or should underpin what we do in medicine. And clearly that is what we try to do at HIC. To make quality, the standard, to make excellence, the pursuit of excellence, our mission. And now, why standards are important is that, standards are continuously evolving. And because as we do research, as we do investigations, we know the right thing to do. Mark talked about exciting new medications coming on stream, right? So some of these medications, for example, some long names, sacubitril, valsartan, for example, that we know is very useful in some classes of individuals with heart failure, and we know when they should be instituted. Before that, we have other classes, ACE inhibitors, beta blockers, and so on. The reason that good outcomes are achieved is when you have standards that are benchmarked to best medical evidence. If we know what the evidence shows, and then we have standards that say we have to practice according to these standards, then people get the outcome of those research investigations that were published. But it's impossible to get the right outcome if you're practicing substandard medicine. And so we think standards are important. And by the way, I'm also one of those people who I don't think there are standards that are applicable in one place but not applicable in another place. One of the things that we have tried to resolve is the assumption that substandard care is appropriate for people who are perceived to be economically disadvantaged. That is not right, in my opinion. Now, we also know there are other impediments, like the cost of care. Who pays for health care? Is health care a right or privilege? If it's a right, whose right is it? And who should pay for those rights? If it's a privilege, who is responsible for making sure that people get advantage of that privilege? We know what is happening in other more advanced societies in the world, and people take responsibilities to make sure that there is universality at least there is an attempt at universality in making sure that people get good quality health care that is standard. So you don't pick and choose who you give optimal care. That's why standards are important to us, and individuals should be given opportunity to know this is what you need. And then we move into affordability. How do we make it affordable?
Standards should be universal.
Exactly.
Okay. So, Dr. Anderson, I'm going to ask you the same question because Johns Hopkins, I mean, it's global in terms of its reputation. In the area of cardiology, what are some of the standards that you strive towards that has kept you on the leading edge of medicine?
Yeah, so I think one of the things that we are thinking a lot about right now is this concept that maybe some of the audience has heard about, which is personalized medicine, which is not just applying treatments in an agnostic way, but trying to understand the patient with the disease, its cause and natural history, so that you can apply the right recommend the right treatment to the right person at the right time.
Can you give us a quick example?
Sure. I mean, I think that there are examples where, based on Dr. Madu talked about the genetics of Jamaica being substantially built upon the genetics of West Africa and Nigeria, and that those genetics may drive certain treatments, say for blood pressure control, as opposed to another genetic background. That's one example. The way drugs are used and metabolized will change according to certain genetic backgrounds. And then also just a simple variable like age. A treatment that would be appropriate in a person in their 80s might be safe and effective for them, but not as well applied to somebody in their 40s who may live for 40 more years and so accrue toxicities from that treatment.
I'm very much concerned about, here in Jamaica obviously, but I wanted to ask you from where you sit again in the United States, the role of insurance, health insurance, as it impacts standards. Is there a relationship there? Because I mean, after all, the conference is about medicine and society.
I think that there's an enormous relationship. The U.S., as you may know, is struggling to answer this question that Dr. Madu raised, which is healthcare a right or a privilege? At Johns Hopkins, we believe that it's a right, and we are deeply committed to taking care of our neighborhood just as well as being leaders for the world. I think we already know with data from the different ways that the U.S. states have adopted the Affordable Care Act or Obamacare, that states that adopted that have already, in the 9-10 years, have seen decreases in chronic disease when people have access, when insurance is not an obstacle. So I think that there is no question that insurance is a tool for access.
As Dr. Madu was saying, when the standard is universal, it was right across the board.
Can I make
I want to ask you about the context of Jamaica.
Yeah, so let me just add to what Dr. Anderson, said. And this is a very important point to drive home. And I think I've said this in several lectures in a public forum, that healthcare is a fundamental human right, right? And that is why you must engage the society in a discussion of how to make that right available to every member of society. It is not something an institution alone can resolve because there is a cost associated with the care. If somebody is going to demand what is a right, then as a society, we have to craft mechanisms to make that right available to everyone. And I'll give you a quick example. In Jamaica, so if we are pushing healthcare as a fundamental right of citizens, then the government has a role to play. Even if the government is not able to provide all the infrastructure and all the resources to deliver that healthcare, the government can facilitate the private sector in delivering this. But if there are policies in place that make it cost prohibitive for the private sector to fill the gap the government is not able to fill, then that right becomes unattainable for a lot of people.
With every right comes responsibility.
Absolutely.
What is the responsibility of the citizen, the client, who ultimately is the beneficiary of this of great healthcare? Speak to the citizen about what they should be doing in order to help themselves, to promote, in addition to institutions and government, the best healthcare possible.
Okay, and so that's every right comes with responsibility. You know, some of the basic responsibilities include taking care of yourself, being responsible, health promotion and health seeking behavior, health behaviors that promote good health, right? In cardiology, we will talk about things like smoking, right? That is one area you can help yourself. That's a responsibility. Exercise, get out of being sedentary, right? There are things you cannot change. One is your gene pool. You can't outrun your gene pool. So at the end of the day, even after you fulfill those responsibilities, there are people who will also need care. Right.
And in terms of government, what should you be demanding from government?
So, we have a good template to follow in Jamaica, for example, right? The Jamaican government values tourism, right? And so they have a list of incentives for people who are building hotels. They have a list of incentives for the tourism industry. If you're a tour operator, you get a lot of things that you're gifted with. If you're building a hotel, somebody said to me one time that if you want to build a hotel from pin to needle, everything is tax exempt. You can bring in. So if we want our citizens to get good quality health care, then we will need to take some of those incentives and pass them over to the health sector so that you can bring in the things that can help people get the right type of health care they need.
Okay. I'm going to give you the final word, Mark. Is there anything that, coming out of this conference, or anything you have, you haven't really gotten a chance to, ingratiate yourself into the culture as yet, but you would have been involved in several of conferences of this type. What are some of the key takeaways that you would like to see coming out of the Masters of Medicine conference?
Well, I think I've been to many conferences, but I think what's one of the unique aspects here is the involvement not just of the medical community, but the public at large, and the ecumenical discussion that does not all require highly technical knowledge and background. But I think the most important thing is for the community in Kingston to be able to benefit from these new therapies and this heightened awareness of the dual role of patient and provider in marching toward a future of better health.
Dr. Mark Anderson, thank you so very much for your presence here at the Masters of Medicine conference, and please, come back and see us again soon.
Thank you very much.
Professor Ernest Madu, what can I say? I mean, I personally owe you, through the Heart Institute of the Caribbean, a great debt of gratitude, because but not for the Heart Institute of the Caribbean, I wouldn't be doing this interview here today, because my life has been saved through that institution, and I'll be forever grateful. Thank you very much for the work you're doing and continue to do.
Thank you.
My pleasure.